Hey, Kendra, can you hear us?
You. Joining me today is Didier, Roxana, David, and Lars. And tell us who's with you there and what are you going to show us today?
Yes, so it's good to be back here in the cath lab. We are in the Alain Cribier room here in the Erasmus Medical Center. Next to me is Rutger Jan Nuis, one of our senior structural interventionalists. And there's also Mario, there is Sanna, there is E.T. or Tom, Quintin in the back. There is Stefan, who is loading the valve as we speak. Claire is here for the echo follow-up. Claire is our expert imager. And there's also Rick Adrichem, who is a fellow, one of our senior fellows, who will discuss the CT. But we have a little bit of a peculiar patient. It's a really challenging case. We had some difficulties in planning this patient because we were having serious doubts on the access. But this is also what TIO is all about, right? We want to have practical issues that you face in your own practice and how to deal with it through creativity. So, Rutger Jan, why don't you start with presenting the patient?
Absolutely. So today's patient is a transcatheter valve implantation with a Navitor valve in a patient with decompensated aortic stenosis and, as you said, complex anatomy. So the patient is an 86-year-old gentleman with a cardiovascular history of moderate aortic stenosis since 2017. He was followed for that in a referring hospital, and in 2020 he received a permanent pacemaker. His other medical history reports a chronic obstructive pulmonary disease in GOL2, and in 2020 he had a stroke. His clinical presentation was decompensated aortic stenosis in the referring hospital with pulmonary edema. Next slide. And his EKG shows a right ventricular paced rhythm, 69 beats a minute. Next slide. And the cardiac ultrasound shows on the left upper, left lower panels a severely stenotic, calcified tricuspid valve. In the right upper panel, we appreciate a diminished or reduced LV function. And in the right lower panel, there is no aortic regurg. And then when we have a look at the Doppler flow measurements, we found a peak velocity of 3.1, a mean gradient of 21, but also an aortic valve area of 0.9. So with these discrepant findings, we sent the patient for a stress echo. And on the left two panels, we see the baseline images, and on the right two panels, we clearly see that there is cardiac reserve, contractile reserve, and there is also an increase in the peak gradient of 3.1 meters per second to 4.4. But most importantly, aortic valve area remained below 1. So with the diagnosis of low flow, low gradient severe stenosis, the patient was worked up further, and the coronary angiogram revealed no significant lesions. Next slide. And with a TAVI in the back of our head, we proceeded with a CT scan, and I would like to ask Rick to tell us about that.
Okay, good afternoon, everybody. I will discuss with you all the CT scan we performed. I will first start with the coronal view of the aortic valve, where we, of course, do the measurements of the aortic annulus, where we see an aortic annulus area of 518.4 square millimeters and mean diameter of 25.7. And if I then scroll up, you see that it indeed is a tricuspid valve with moderate calcification of the valve.
So Rick, if you then briefly scroll back down, what is quite peculiar, and I hope you can appreciate it, is the thickness of the leaflets themselves. So if we can bring on the CT scan again, look how thick the valve leaflets are. And this is already a little bit of a concern when implanting a transcatheter heart valve. So the stability of the valve during the implant might be suboptimal. So that might be an indication to do the implant using a rapid pacing. Please continue, Rick.
Then if I scroll even further down, then we can see that the LVOT is non-calcified and that the membranous septum, which we measure in this area over here, is about 3 millimeters deeper than the aortic annulus level. Then we also look at the optimal projections, where we see that the optimal projection is at an LAO 5 and a caudal 20 view, and we also look at the cusp overlap view, which we can see here, which is at an RAO 24 and a caudal 37 view. Then if we go on to look at the femorals, we can first see that there's a very tortuous anatomy of the femorals. And then if we scroll down past the right artery, the right femoral artery, you see that this is severely calcified and that the minimal area, the minimal diameter is only 4.3 millimeters in diameter. On the left side, we see that the artery is less calcified, but also that there is a very severe stenosis at the level of the external iliac femoral artery, which is a minimal diameter of 3.9 millimeters.
So Rick, if we see this, typically we would consider alternative access at this point, right?
Yeah.
Because these vessels are severely diseased. There is so much calcium. And if anything, there might be something to be done on the left-hand side, but still the vessel size was less than 4 millimeters,
Yes,
correct?
That's correct.
Okay, so then our next step would be axillaries.
So yeah, we looked at the axillary arteries as well, which you can see here. If I get at the stretch vessel view, then we first look at the right axillary artery, of course, and also this one is severely stenosed with a minimum diameter of 3.7 millimeters, and on the left it's also not very large with the minimal diameter of 4.7 millimeters, but also there's of course the pacemaker located on the left side.
So that might complicate an axillary approach, and on top of that, also the landing zones for a potential embolic protection device with filters is also suboptimal because of the atherosclerotic disease around the landing zone.
That's correct, yes.
And then maybe you can quickly switch to the abdominal aorta, because also there, this is at the level of the renal arteries. There is circumferential calcium. It's really a hostile environment there. And we believe that also from a transcaval point of view, this might be quite a challenging endeavor. So the question is, so we have two major challenges here. The first challenge is I'm a little bit concerned about the leaflets in this patient with low flow, low gradient aortic stenosis. So will the valve remain stable as we are deploying it? And second, the access is really an endeavor, I think. So we all have seen now the anatomy of the arterial system. Now the question to the panel and to you, Kendra, is how to move forward with this patient. What would be your approach in terms of access?
Well, I think the one area that you haven't exhausted is he a transcarotid candidate? And then, of course, us being a transcable first, we tend to really kind of push our boundaries in that. And so I know that's what I would do. But Roxana, what do you think?
Well, really difficult case, and I don't know what you think is the caliber of that right femoral artery so small that you wouldn't even consider using shockwave to really help you get your devices across. Whatever I could do to do a femoral approach is what I'd like to proceed with, and that's sort of our motto. And then, of course, if worse comes to worse, a direct aortic approach is yet another. But I think we would probably see if we could still do the right femoral on the right side. I mean, there is also a severe tortuosity, so you'd have to deal with that as well as perhaps using shockwave to navigate your way in.
Yeah. So, Didier, what do you think?
So this is definitely an extremely challenging patient, but I really recognize your selection, but I'm sure that you're going to handle this patient very nicely. So if it was my patient, and given the fact that he deserves a treatment, there is no major access that is suitable, I would still try to go through the femoral access, but you need some debulking strategy, so it would be pre-dilatation, sequential, gradual predilatation, increasing the diameters of the balloons and using the shockwave. I guess it could be interesting. And then probing the vessel with a sheath, something quite hydrophilic and slippery like the Centron, for example, or a gore sheath, and trying to see if you can bring something bigger within the vessel. But the choice, I have to say that the choice of the device is also important. The Navitor with the FlexNav system. The FlexNav system is potentially the most suitable delivery system for this type of peripheral vasculature. But you need to prepare the iliac and the femoral artery beforehand. That would be my advice.
Yeah. Any comments, final comments from you, Lars?
No, I agree. I mean, I haven't seen all the details on the access vessel, but it looks to be almost circumscribed calcification. So I think it will be a good case for shockwave and an inline sheet or expandable sheet. I think that will be doable. But of course, also having a safety wire, be ready to bail out in case of a severe vascular complication.
Yeah. Yeah. So, okay,
So
let me
Nicholas,
tell
we're
you
down
what
to about
we
4
did.
minutes before we're going to
Oh,
go
yes.
to Colombia.
Yeah.
No, perfect.
Yeah. So what did we do? Yeah. So we obtained a right radial access. Then we put a needle through the skin for pacing on the wire later on. And what we did was we did an ultrasound-guided puncture first with a 4 French sheet in the superficial femoral artery, and that is our safety net for whatever might happen later on. And then we went in, we did ultrasound-guided access of the common femoral artery, inserted a 6 French sheet, made an angiogram, and we can briefly show the angiogram maybe of the femoral. So this is a DSA angiogram, where you can see that there is extensive vascular disease, atherosclerotic disease in the mid-segment of that vessel there. But the puncture site is relatively high, but this is based on ultrasound. So we avoided all the calcium around the puncture site. And then our aim was to first go in on the left side with a 7 millimeter peripheral balloon, provided that the sheet was not crossing. But to our surprise, and maybe we can also show the sheet insertion, the sheet went in very smoothly. And this is a dry seal gore sheet, 14 French, and it went without any hiccups. So that can be a blessing, but it can also be a curse, because now we are committed with this sheet. So what we're about to do is we're going to put in a safari wire, and then we're going to use the FlexNav, as Didier was mentioning, to implant the Navitor valve. So we will do no further treatment in this patient with a 3.9 millimeter dimension-sized left femoral artery. The reason not to go to the right side was the circumferential calcium. That would be very attractive for a shockwave balloon, but there is this tortuosity that Roxana also mentioned. And the combination of tortuosity and long circular calcium, that is also a recipe of disaster. Because don't make no mistake, when you do shockwave balloon inflations, vessels can rupture, and unfortunately we lost one patient some time ago because of that. So we are very sensitive to this combination of tortuosity and calcium, and yeah, we took our chances on the left side, and it turns out to go smoothly so far. So what we're going to do is we're going to continue with the valve implant as you move to New York. And then when you're done in New York, you will be coming back to Erasmus, and then hopefully we can show you the valve implant, and then we will take care of the closure, which probably might end up being challenging as well, because we already used 4 Perclose Pro styles as a pre-closure. So we'll take it from there.
Thank you, Nicholas, for the great demonstration of what to do with challenging anatomy. We can't wait to see the results at the end. But we are going to head to New York and the team at Columbia with Sushil Kadali and Isaac George.
Hi,
Hey,
can you guys
Sushil
hear
and
us?
Isaac, it's Kendra. Yeah, I can. I'm joined today with by Didier Cheche, Roxana Moran, David Hildrich-Smith, and Lars Sundergaard are on our panel. Thank you for joining us from New York. What do you have going on there?
Hi, Kendra. Hi, everyone. Thank you and welcome. Isaac's not here today, but we have Dr. Takeda as our surgeon stepping in. Welcome to our new cath lab, relatively new, 6-month-old room here. We have a large team here. We have Vivian Ng, interventional cardiologist, Torsten Wall, interventional cardiologist, Chris, our specialist, Mark from Edwards, Margaret and Michelle from nursing helping us out, and Becky, Mark, and Petita from Echo, and we have Joe from anesthesia. But just in the interest of time, we're going to get to the case presentation that Nino's, our wonderful structural fellow, is going to sort of walk us through this case. And we were asked to talk a little bit about the issue of coronary disease and AS and how to manage it. So that's what this case highlights. Nino?
Hi there, everyone. So we'll start with the case presentation. Next slide. This is an 82-year-old gentleman who presents with a worsening 6 months of breathlessness and fatigue. He also reported intermittent dizziness. His past medical history is most notable for atrial fibrillation. He had a left carotid endarterectomy in 2014 and a prior stroke. His home medications are listed there. Next slide. As part of the initial evaluation, the transthoracic images were suboptimal, and we elected to present here the transesophageal images. You can see that the patient has severe aortic stenosis with a type 1 bicuspid with right to left fusion. The quantitative parameters on the right, there's mild to moderate AI, preserved LV function, and aortic valve area that was calculated at 0.9 centimeters squared. As part of the evaluation for potential aortic valve replacement, he underwent a coronary angiogram. Next slide. Representative images of the left system are illustrated here. You see a patent ramus on the left, and then the cranial shot on the right, a suggestion of focal tight calcific stenosis of the proximal LAD just prior to the takeoff of the first diagonal. Next slide. The LAO cranial shot on the left further illustrates the focal LAD stenosis.
Can we get these to play there, please? Yeah. There you go.
And then of the right system, you see first a totally occluded right coronary artery, and then an anomalous common origin or adjacent origin of an anomalous circumflex with disease in the mid portion of the vessel. Next slide. For further evaluation of his candidacy for aortic valve replacement, he underwent a cardiac CTA with contrasted evaluation of his abdomen and pelvis. Next slide. On the left, you see the confirmation of a bicuspid aortic valve. You can also begin to appreciate the course of an anomalous circumflex adjacent to the non-coronary cusp, which is calcified. And then on the right, you see our CT measurements with a valve area at 532 millimeters squared and a perimeter of 84 millimeters. Next slide. He had large sinuses and high coronaries. Next slide. And an assessment of his peripheral vasculature, the sizes are noted on the right. You'll appreciate particularly on the right common femoral artery a fair degree of calcifications, which we'll discuss in terms of our procedural planning. Next slide. I'll summarize what I've said so far and then maybe start some of the points of discussion. So this is an 82-year-old gentleman. He has severe symptomatic aortic stenosis with a type 1 bicuspid and also has multivessel coronary disease. We convened a multidisciplinary heart valve team meeting. His STS score there is 4.4%. I will draw your attention to the 25% predicted morbidity or mortality related to an aortic valve replacement, surgical aortic valve replacement, and bypass surgery. It's also quite frail, and yet bicuspid anatomy that we thought was reasonable for consideration of transfemoral TAVR. There are also no concomitant high-risk features. Next slide. So based on that evaluation, we thought we'd start the conversation with what to do about the coronary disease, often discovered somewhat incidentally in the evaluation of patients with aortic stenosis. There's three things that we weighed in our considerations, the first of which is the coronary disease a potential contributor to the patient's symptoms, which may increase our threshold to potentially intervene. The second is, do we feel that the coronary anatomy is a risk factor or potential would the safety of particularly rapid pacing during transfemoral TAVR be compromised with the burden of coronary disease? And the third is, how does the selection of the particular valve choice impact our ability to reaccess or intervene on the coronaries at a later date? So maybe I'll stop there and turn it over to Sushil and the group.
You know, maybe if we can sort of have a little bit of discussion here on these slides. So, wait, can we get the slides back up, please? Get the slides up, please. So, the first point is, does the coronary disease need to be treated? And, I don't know if it's worth, Kendra, do you want to stop here, have a little bit of discussion, answer these questions? What disease needs to be treated and what can be left alone?
Yeah, I think that this is a great time to dive into that a little bit more. Roxana started this afternoon with a presentation on this topic. So, Roxana, does it need to be treated at all, that proximal LAD lesion?
Yeah, I'm actually more concerned about that anomalous circ and access to that anomalous circ that post TAVR that might have an issue down the line. But I also am worried about that proximal LAD. I mean, I guess, you could think about, those are both pretty tight lesions. Whether you do it before or after, it all depends on, I think, what valve you're choosing, what's the height of the coronaries, and especially in that anomalous, the anomalous one off of the cusp of the right. So, I mean, I personally would say, and I also, by the way, I think I saw a little bit of an MR on that echo. You didn't notice, you didn't mention it, Sushil, but if there is MR and that circ is tight, I would really like to have seen that MR, the circumflex treated, because it could be an ischemic MR for, I mean, if unless I saw it wrong, but I thought I saw some MR.
Yeah, and we're going to go through a little bit more of the echo with Becky here in a second. I think our perspective in terms of the coronaries is often, do we think the patient is symptomatic from the coronaries? Do they have angina? Let's stay on the slides, please, if you don't mind. Just keep clicking through and stay on this slide. Do we think they're having symptoms from it? Do we think it's going to impact the safety of the procedure? And then a little bit of, what valve are we going to put? How difficult is it going to be to treat after if we don't treat now? I think those are all important considerations. And especially you mentioned the anomalous circ, that access may be difficult. And in this scenario, we thought this was significant proximal, three vessel disease, right? I mean, I understand it's mid LAD, but it's really quite proximate. There's a prox circ essentially with the anomalous and the right's totaled. If this was a significant consideration for us, if this patient was lower risk, this is something that would sort of push us to say this patient should get a CABG AVR. It was really felt that this patient was high risk, and that was sort of the reason why we elected to do TAVR. And with this degree of coronary disease, felt that it needed to be treated. I think, this, if you go click one more time, this does impact the valve choice question as well. No, just stay on the slides, please. Stay on the slides. Just click one more time on the slides. This does impact the decision about whether which valve choice we do, a short frame, the anomalous circ, and everything else. And so, those all factor in. I think because of the complexity, we elected to do it first. And I think if you're doing it first, the question is, what are the issues regards to, do you do a BAV? Is the patient going to be stable? Is this a high-risk PCI? These are all important considerations. And, we also are enrolling, Vivian can talk a little bit in complete TAVR. We don't necessarily fix all these lesions, and some of these lesions can be left alone. I don't know, Vivian, you want to make a comment on that?
Yeah, I think that everybody has made really good points as to the decision-making process and things that we consider as to whether or not we're going to fix particular lesions prior to a TAVR. But this question becomes particularly important as we start doing TAVR in lower-risk patients. Should we be doing complete revascularization in low-risk patients who are undergoing TAVR, the similar way that you would do a CABG AVR. So the complete TAVR trial, and I know that this has been discussed a little bit earlier in the session, is enrolling patients and randomizing them to either medical therapy or to PCI, complete revascularization, after a successful TAVR, and following these patients to see, is this going to improve their symptoms? Is this going to improve their overall mortality and survival?
You guys saw, obviously, this
and
is a scenario where we're going to do PCI first, because we've shown you a little bit on the slides, but would anyone do this differently from the panel side? I was just curious.
Yeah, I mean, we would.
Well,
we would
specifically,
not treat
David
this
mentioned before.
Yeah, we would not treat this first. We would treat the valve. I mean, as long as the valve was unequivocally severe, we would treat that first. If the patient had symptoms of angina after the TAVI, we would then treat the LAD.
Mm-hmm. Anyone else? Any other comments, or should we move forward? I mean, part of our rationale is, it is triple vessel. I think this is prognostic CAD with triple vessel disease, and we did sort of go back and forth on it. He doesn't have clear angina, so that it's an important point. And I thought part of it was the complexity of the disease after would also be relevant as well.
Yeah, I mean, this requires.
I'd love to know what Didier would do.
So
Didier?
it's clear that we don't have any 100% clear answer to that question of coronary artery disease. So it has to be based on an individual assessment of the patient, and we have to wait for the trials. If it was my patient, having said that, I would have treated the coronary arteries before, because it's a complex anatomy with the bicuspid. It's a complex coronary anatomy with the anomalous origin of this left circumflex. So I would treat everything before moving to the aortic stenosis, but for this particular patient.
Kendra, if it's okay with you, in interest of time, we'll go forward.
Lars
or...
does.
Oh, sorry. Sorry, go ahead.
I was just going to ask Lars which valve he would choose in this situation.
Yeah, I would choose any valve where I was sure to be able to access the coronary arteries afterwards. You could use a balloon expandable valve with a low stent frame. If you use a self-expanding technology, again, be sure you have commercial alignment so you will be able to access the coronary arteries. I think that's the most important thing.
Okay, go ahead, Sushil. Tell us what you decided to do.
Okay, next slide.
So we elected to upfront proceed with PCI of both the LAD and circumflex through the right radial. We started with the LAD and a 2515 NC, where you could appreciate dog bone in the mid portion of the balloon. We then took a 3.0 by 12 shockwave, and you could appreciate even within the first 4 or 5 pulses of delivery that the calcium cracks in the balloon begins to expand.
Non-compliant was at like 24 atmospheres. Just it would not yield. It was a very focal napkin ring in that LAD.
Next slide. We thereafter delivered a 3528 Zion stent that was post-dilated with the 35 NC, and in the interest of time, we'll forego the IVUS images, the final angiographic result of the LAD seen on the right, and the mean stent area at the end was 6.3. We then directed the attention to the anomalous circumflex. Next slide. There was some challenges.
Next slide, please.
Some challenges with equipment delivery. So an AL.75 guide is used with the buddy wire, and the lesion was successfully pre-dilated with the 2515 NC. Next slide. A 3.0 by 34 Resolute was then delivered and overlapped with approximately the 3.015 Resolute that were then post-dilated to 3.0 and a 3.5 NC respectively, with the final results seen on the right. Again, the MSA there was just about 4. Next slide.
So now at this point, we had sort of planned, this was staged, this was about 2 weeks ago. Patient is proceeding with TAVR with SAPIEN 3. I know there's different ways to do this. In complex bicuspid borderline sizing, especially with the balloon expandable and a calcified raphe, unless the patient is high risk for intubation and anesthesia, we've done TE guidance for these type of cases. The majority of our cases are awake, but in complex anatomies, borderline sizing, calcified raphe, bicuspid, we believe strongly that having complete imaging is important. We use embolic protection in more than 90% of our cases. This gentleman unfortunately had significant plaque at both ostia that we felt that it was not safe to do embolic protection. If we can switch back to the other screen, we're going to have Becky go through the echo images. We'll end the PowerPoint, and then we'll tell you where we're at.
Okay, great. Is the echo up?
Yep, echo's up.
Yeah, so just a real rapid tour through the heart. Obviously, there's no significant mitral valvular disease. The LV function is hyperdynamic. As you can see here, it's a small cavity, so bear that in mind for some of the other results that we'll see. This is the bicuspid valve seen in the biplane view, clearly flow only in the horizontal commissure. You can see the raphe here at 6 o'clock. And then three-dimensional imaging very easily
shows you the bulk of calcium everywhere along that valve, again, causing almost a double orifice across that, that linear commissural line, as you can see here in the direct short axis views. We looked for the coronaries. That's obviously the LAD. There is no circ. We did find it later on, and you can see here a calcified circ coming around both on 2D and on three-dimensional imaging. LV function remained quite normal, but it is a markedly thickened valve, and so, ventricle, so likely to have abnormal strain imaging, which may account for some of our hemodynamic findings. You can see from a transgastric view, very, very calcified valve, very small opening, small vena contracta, and of course, a high gradient. Now, the peak and means here were only 38 and 21, but the valve area calculated to 0.9. And in that setting, we went ahead and also planimetered this at 0.85, confirming that it was indeed severe aortic stenosis. I'll just back up for 1 second and show you that planimetry. And so the only other question was why the gradients were so low, and it turns out this patient has low flow. You can see the stroke volume is 75 for men. The abnormal hazard ratio occurs at a stroke volume of 40 instead of 35. So this patient has 37 mils per meter squared, and therefore is obviously in low flow. Now, we went ahead and sized.
So I think this is an interesting question, and this time we'll move forward. But on CT, we get areas of 530 to 550 at the annulus. Above the annulus, you know, in terms of superannular, they're a little bit smaller. But on T, if you go a little bit below into the LVOT, we get 550 to 570. It's a bicuspid. The intercommissural is around 29 to 30. Becky got a little bit bigger at 31. So the question is, how do you size this valve? We use 26 or 29. Our thought was to do a balloon with a 25, look at it what it looks like on echo, and make the decision. Any thoughts from the panel? Will we go up with the balloon?
Didier, why don't we start with you?
So it's true that this is a borderline case in terms of sizing, with the supraannular measurements being greater than the annular dimension. Balloon sizing may be useful, but what I would have done differently is to use the circle method. On the CT scan, you put a 26 circle within the anatomy of your patient, and you may anticipate what is going to be the overall interaction with the surrounding structures, particularly the risk of sinus sequestration. So I guess here a 26 could fit, but we're going to get more details with the 25 millimeter balloon. For this patient, I would use a 26, maybe slightly overfilled, rather than a 29, because there is potentially a higher risk of damaging the sinus of Valsalva due to the calcium burden in this particular anatomy. So let's see what a 25 does, but my guess is 26 sapien free is going to do the job.
So can we get both echo and fluoro
after your
on the
balloon,
transmission?
we're going to have to go back to Erasmus.
Okay. Okay. So we'll go ahead. So we'll do a small injection. Everyone ready? Pacer on. Becky, you ready?
I'm ready.
Yep. Inject. Pacer off. So I think a 26 should be okay based on that. What does the panel think? Or the 25 balloon?
That looks like a good size valve. You sealed adequately with a 25 balloon and a good injection. So I think that your assessment is correct. We're going to leave you for a minute. You guys keep working, and we're going to head to Erasmus because they're ready to implant their valve.
Perfect. Okay, we'll be back in a second.
All right, Nicholas, we're back to you.
Hi, Kendra. Yeah, so I have to say that we finished the valve implant more than 10 minutes ago. Everything is going very smooth. I don't know what happened, but let's briefly show the valve implant.
That's a good problem.
So this is a Yeah, it is. So this is a very sweet deployment of this Navitor valve that really stayed. It had a slight inclination to move inwards, but we anticipated it that it would be a little bit of a bumpy road because of the thickness of the leaflets. But we used also RV pacing. So if you go to the next image, so we used RV pacing to deploy the valve, and then eventually we decided, okay, we're committed here, we're happy. And we could have gone slightly higher, but you'll see the final result. So then volgende. En volgende. And so this was our result by angio, but then Claire made an echo. And then Claire, maybe you can comment on the echo?
Yes, so after the deployment of the valve, we appreciate on the 5-chamber view that there's quite significant leakage.
Yeah, and that triggered us to proceed with a post-dilatation with a 26 millimeter balloon. And then after that, Claire, what did you see?
Yeah, so this is after the post-dil that we see, the PVL was significantly improved, but yet still see some jets over here. I would say it's trace.
Yeah, and then we made another angio, and we couldn't, and can you show the final angio in the cusp overlay view? And there, all of a sudden, there's nothing anymore. So a nice positioning of the valve, and we don't see any PVL anymore. So Claire made another echo, and
so
then
this
Claire?
Is something like after 5 minutes, after the deployment and post-dil, that I was really trying my best to locate a jet, but I couldn't find it. So apparently, there was no PVL anymore.
Yeah, yeah. So the seal does its work. There's also the nitinol that keeps on expanding. So this is, I think, a very nice result. And what also was of interest, and Quinten, maybe you can show the introduction of the FlexNav. So it always remains to be seen how the delivery system will proceed next. Here. And also that went very smooth. So we were quite pleased with how this case was going so far. But now we're faced with this diseased left iliac vessel where we have this 14 French system in situ, and we have to take that out. So
maybe
if you
one
agree,
question
we can,
for you, Nicolas.
Yeah.
Just about the, because this is a really contemporary practice, we know that devices are going to seal. We're going to get no regurgitation in the vast majority of the cases. But we discussed during the previous symposium about the commissural alignment. What do you reckon for the Navitor in terms of handling the delivery catheter to get a proper commissural alignment?
Yeah. That's a very on-topic question, and I totally agree with you. The stakes are much higher now. We have to be considerate for coronary accessibility. So we also try to achieve commissural alignment, and so with the NEO commissure. Lars did a lot of research on that, and we typically use his recommendations. So we inserted the system with the flush port upwards at 12 o'clock. And that gives you already a high likelihood of commissural alignment. And then, as I mentioned, we used the conventional coplanar view, but also the cusp overlap view for commissural alignment. Not for our depth implant determination, but for the commissural alignment. And if you look at the final angiogram, the last angio, there you can see, you can tell that that there is commissural alignment. So what you want to see is that there is one post isolated on the right-hand side, close to the inner curve, and that is exactly what we are having here in this 86-year-old patient with only luminal irregularities in his coronary. So for this patient, I don't think he will face any coronary issues down the stretch. But it's good to be to know the technique of commissural alignment. Lars, do you have any comments on that?
No, I mean, if you are here in a right-left cusp overlap view, and you can see you have at the top of the frame, the outflow portion, you have one tap on the right-hand side, and the two others almost overlapping on the left-hand side, showing that you have close to patient-specific commissural alignment. At the same time, this valve have intravenous leaflet position. It got very large stent cells, so I'm sure you'll have an easy job if you one day need to access these coronaries.
Yeah, yeah. So maybe we can show you then the closure, the access site closure. And again, we have this 4 French sheath in the superficial femoral artery on the same side. That is our safety. And we're going to give some protamine right now. And can I have some water? Let's make the sutures a little bit more wet. Beetje koud, meneer. Voilà. And then Rutger-Jan can withdraw the sheet. And this dry seal sheet is such a sweetheart. Oh, God. So we used 4 of these sutures. 2 were torn apart during the pre-closure. So there is always a chance that you will tear another one as you are closing the pre-closure, obviously. So we're cognizant about that. But this looks very good. So I think this is immediate closure. And Didier, we know that that is somewhat exceptional with 2 sutures. Oftentimes you need an additional closure. We've learned that from the mesh trial. But I think Herrier can pull the wire, and then we'll make a final angio through that 4 French sheet that we have in the superficial artery. And I really like this safety.
I have changed my practice, moving from 2 proglides to only 1 proglide and an angio-seal. And particularly in these very small vessel calcified, it prevents more frequently this residual stenosis at the end of the procedure or even bleeding. So I found it to be more efficient, particularly in the challenging vasculature. 1 proglide and a plug on top of that. What about the Manta, Nico? You were using that device very frequently in the past. Do you think that is suitable for such vessels?
No, I think here you have to be prepared for some bailout options, and there was no bailout option, or there is no bailout option when you use a Manta device other than a covered stand. So we want to try to avoid a covered stand. That's why, we would not prefer to use a Manta here. Can we move the screen distally, please? Thank you. All right, so let's DSA. Let's make one bigger. Okay, Herrier, you ready? Yep. That's good. That's a sweetheart. That's good. Perfect. Yeah, that's the contrast
Beautiful
on top of the
result
patient
in
that
demonstration
escaped.
there.
Yeah. So basically what we're going to do now is we're going to finish up by putting in another proglide in that SFA. And then we have finished this quite challenging case that went basically to our satisfaction. And this, by the way, was an 86-year-old male who lived in a small village on the border next to the village where my late grandfather, was the mayor after the World War. Oh. So, and he knew my grandfather. How cool is that?
Oh, that's outstanding. Well, Nicholas and the team from Erasmus, thank you so much for that wonderful demonstration. We're going to head back to Colombia to see the conclusion of their case.
Fantastic.
Thank you all for great work. Thank you.
Congratulations.
All right, so Shia, we're back with you.
Yeah, perfect. So we just started introducing the valve in. You can see if you can show the echo as well, you can see the post-PAV, not much of a difference, but maybe slightly better motion of the valve leaflets. What do you think, Becky?
Yeah, it's definitely a little bit better, but there's also a little bit more aortic regurgitation.
The other thing that, we never discussed earlier is that we're going to flex here, pull the wire, make sure we don't touch the arch. We're going to go back into our view before we cross. The one thing we didn't discuss is this anomalous circ. And, Torsten, we've always sort of theoretically talked about it. Any concern that you pinch the stent or the artery or?
Yeah, I mean, luckily the aortomitral curtain tends to move out of the way and there's enough of a cushion around the annulus. But in theory, we early on have wondered if a balloon expandable valve, for instance, would give us ever trouble with that. And if you stent the vessel up front, can you perhaps interact with that stent in a meaningful way? But like you said, we've done about a handful of cases now not 100, but we've never seen any problem like that in those cases we've done. I mean, I have to say, I really like always this discussion about the coronary arteries, and ultimately, I agree that we tend to be less aggressive in particularly elderly patients, but on the other hand, when there's a lot of complex disease and you worry about having to use heavy equipment, I still prefer upfront personally.
So one question about the projection that you are using.
One other thing to think about. Yeah, go ahead. Go ahead, Didier.
No, it was just about the projection that they are going to use, because as it is a bicuspid, is it a kind of free cusp coplanar equivalent or a cusp overlap equivalent?
It's a three cusp equivalent in this case, but there's some tortuosity in the aorta, so it actually happens to be a straight RAO view.
For balloon expandable, I know
Roxana,
people
what
are
were you
using
going to
more
say?
cusp overlap, but we haven't really done that routinely. We started to in some cases with a high implant, but here we have echo to guide us as well. Sorry, go ahead, Roxana.
No, I mean, I think the other thing that we didn't talk about, which I think is really important in these frail patients, is the antiplatelet, antithrombotic regimens that this patient will now need, because you have 2 proximal artery stents in there, and if they have a really high bleeding risk, you definitely are going to need, and I know that this patient was on apixaban. I think I noticed that and one of the medications this patient was on, he's had his previous stroke, so he's pretty high risk. And I guess that's another consideration. And as far as like, well, maybe not touching the coronaries, because then you'll be like, you won't need to deal with it. But I certainly, in this case, would have gone ahead with the plan as you've done it, and probably send this patient home on clopidogrel and apixaban. But I'd love to hear what you're all thinking about that.
It's tricky, because in this case, you know, the patient's aortic stenosis itself wasn't, in fact, unequivocally severe. But on the other hand, as Lars pointed out earlier, in the only study we have, the activation, there was quite a lot of excess bleeding in an era when most TAVI patients also had dual antiplatelets, which is not the case now. So, you know, there is an option for saying, okay, you just give them their usual apixaban, you just do the valve, and you don't treat the coronaries, you know, unless they have angina. But who knows what the right answer is?
You know, you're absolutely right. You could argue this anyway. I mean, my feeling in general was we leave most coronary disease alone, to be honest. But this was, in my mind, independent of the valve, prognostic coronary disease. He is, you know, elderly, and he's not really frail, but he is sort of higher risk. And you can argue what's prognostic in this gentleman. But we did feel it was prognostic. There's proximal vessel disease. And we went back and forth. But to your point, Roxana, we did do, that's what we did. We did just Plavix along with the apixaban.
No, I absolutely agree with you, by the way. That's exactly what I would have done. I just wanted to kind of make that point for the audience.
So we're just going to go ahead and deploy. So we just for a second, and so then we'll continue the conversation if it's okay with everyone, since we're here.
Yes.
We're across the valve. So we're just going to look on echo as we deploy and watch that we don't injure contralaterally to the raphe, and watch a slow control. Becky, what do you think of our valve position?
Valve position is good. You're just below the STJ, so it should be just fine. I'll watch for calcium.
We're going to try and get a little high, as high as we can on this. We want to make sure that the valve is above the leaflet tips, especially in bicuspids and tall bicuspid valves. If you land short of the leaflet tips, that can make your valve move ventricularly. So, Becky, we're above the leaflet tips, so that's good. So,
yep, above the leaflet tips.
If everyone's ready, then we'll do pacer on. Becky, looks good still?
Yeah, looks very, very good. Position is perfect.
You want to come up just a hair, maybe, Carson?
You can come up.
Yeah, we're dialing up just a hair. Good, you dialed up. Good. Okay, dial in just a hair. Sorry, back and forth. Okay,
everything good, very good. There's no threatened aorta. The aorta looks good.
Pacer off. How does valve position look?
Valve position is good.
So if we can go echo full screen. Yep, perfect, thank you. So we've been trying to air really high on these bicuspid.
That you...
I'm sorry?
Yeah, just to highlight one educational point, because you just rotated the C arm, and potentially you are more, you went to closer to a cusp overlap projection. What is recommended nowadays for bicuspid because you only have 2 cusps. And the most frequent phenotype is type 1 left to right, and that's what you see better in the RAO caudal projection. And
I'll go more
you did
here for
a very nice job. But just to highlight that point in terms of...
Here, to your point here, I'm going to go really steep. This is RAO caudal in him. He is a little rotated, so this is a RAO 32 caudal 24 projection here.
Yeah, and you see that you have that perpendicularity with both the axis of the device and the annulus.
Is there any PVL, Becky, or?
There's a little PVL at a commissure, but you mostly have wire PVL right now. Central. So if there's any way we can get the wire out.
Manipulate a little bit, maybe advance it because it looks like it's coming back across.
Yeah.
So, that was only a nominal 26. I had 2 extra, but I didn't deliver it. It felt very tight with, just with still an under-deployed, even at 2.3 under a 26, it felt very tight. I gave to it nominal size, but I did not give the extra 2 because it was already feeling very full.
So Becky, can you show us the paravalvular leak again? And determine if you think this needs to be post-dilated?
Yeah, just we prefer to do it from a gastric view, so that's why I just immediately went into a gastric. But some of this is central, so yeah, I don't want to overcall the regurgitation.
And the hemodynamics, the diastolic pressure is 90. It's 150 over 90. You want to show the hemodynamic. It doesn't look like a AI type of hemodynamics.
Yeah.
It's kind of small there, but I don't know if people can see it. But
and to me, this looks right now more central, but you do have a little leak right there. And then I'll show you the short axis view. So that's the PVL at the commissure. Remember, it's a horizontal commissure. So at 3 o'clock was a commissure, and then the rest of it looks like it's in the middle of the valve. So it's maybe wire related, maybe expansion related.
So
but anyway, that's the commissural PVL at 3 o'clock.
So there are 2 options. We can hit it, and I can try to give a little bit extra. And I think sometimes with the second inflation, even if it's nominal, you get a little bit better expansion. But what you see here is that we're pushed to one side, right? In this view, Becky, if you can comment, because of the rapid, we're not opening in one direction fully, and that's pushing us. So, I don't know if we'll seal in that commissure for that reason, but we can always give the same volume back. I felt safe doing so in terms of contralateral injury. Becky didn't see anything.
Nothing.
So
yeah, you could see how the valve is really pushed posterior in the aortic root because that commissure was so asymmetric. But the expansion, the position otherwise is really lovely, I think. You can really see it well from that orthogonal view. And then that central is typically wire from the wire.
It's just the wire, isn't it?
Yeah.
So what do you think, Becky? Should we post it or not?
As I see it, it's a trace to a mild PVL in an 86-year-old gentleman who got mild to moderate AR before. I would not push that, to be honest.
Yeah, it's really just in that commissure.
You think it's mild, Becky?
I think it's mild, and I also think it's unlikely that another dilatation is going to open up that commissure.
Let's get a catheter and get hemodynamics and do a quick angio, because I know we're running out of time here.
No, Sushil, we'd like to see the final root shot as well. But
exactly.
While you're exchanging, David, what do you do with this? What if this patient is a 65-year-old and not a 95-year-old or 85-year-old?
I mean, it's usually no harm if you want to post-dilate with exactly the same volume just to get rid of any recoil. But what we saw on the echo there was wire-related leak. So I didn't see anything around the frame. I would do a pigtail shot right down next to the valve so we could see if there was any leak. Probably isn't any leak either side of the valve, so we'd take the wire out, and that's hopefully the end of the case.
But I think your point about a 65-year-old, Kendra, if this is a 65-year-old that you brought for TAVR with a bicuspid, you better get a perfect result before you leave the lab. And I would be more aggressive. But I think at this point, with an 86-year-old, I mean, I feel good as long as you do the hemodynamics and you're not feeling like you're leaving much AI behind. I think you're fine to stop.
Yeah. If this was a 65-year-old,
and that's where I was
you would
going,
have had
Roxanne.
surgery.
No central resolve.
central resolved with the wire
Well,
out.
patient preference now plays into it. So if
And
you know
now-
if you have a 65-year-old who's refusing surgery, you still should be treating him. And the question becomes, Didier, is it okay to leave mild? Is it okay now to leave mild?
So I would say no. No, for low-risk patients and low and intermediate risk patients, we should leave the OR with 0 regurgitation because we know that we can achieve that. Even for bicuspid, and I would say that if the patient, I agree, if the patient was younger, I would go a bit more aggressive because we were in the borderline zone between 2 valve sizes, 29 and 26, so we have to make sure that the device reaches at the maximum 26. And if Becky can just measure the stent frame, it must be close to 24 something. So I guess in a younger patient, I would be slightly more aggressive just to get the maximum expansion of the device. But here the result is superb for this particular patient. It's a high position and a mild regurgitation. 85, it's okay. Yeah.
But it's not a perfect
So
result.
you were saying it's mild?
Yeah, I mean, it's not a perfect result, so that's the question. It's mild. I'm going to check LV EDP here in a second.
I mean, you have AI. You see it.
Yeah, exactly. So this is not, and so this is the question. Is this an adequate result? And let me I think the hemodynamics here do help me in this 86-year-old. If the LV EDP is low, then I feel comfortable.
One small comment. One small comment, if you post-dilate, the short frame is going to foreshorten furthermore from the bottom part. So you're going to get even a higher position as compared to what you have so far. So maybe in this particular scenario for this patient, with that position that you have, not going for a post-deal makes sense because you're going to get slightly higher. The device is going to expand in diameter, but to foreshorten furthermore. So it's going to be higher, I guess. So.
Let's see echoes. Can we see echo after the stiff guide wires out of the LV?
Because at the moment you have what, a multi-purpose catheter in there?
Yeah, correct. Becky, can you show them the transgastric
I mean, you need
here?
to see something without any catheter in.
Yep. So this is obviously transgastric view, and we can hold on, just zoom up on there for you. And this is the leak. So it's obviously off to one side. So if I just go off axis a little bit, you'll see the width of the leak a little bit better. That's the PVL, but it is definitely all PVL. It's not. It's no longer central. So we're able to obviously see it on multiple different modalities, but it's not central. And the gradient, I think, as you already saw, is only 3. So the result as far as hemodynamics of the valve is quite good. And the only question is if you want to take care of the mild PVL.
Okay, here we're going to help us make the decision real quick. We're going to show you the hemodynamics just before you leave, Kendra, if that's okay.
Yes, please.
Can we zero both transitions?
I'm not sure that you can do anything about the PVL here. I mean, there is some PVL, which I must say I didn't see before. I would leave it alone. The valve is going to come slightly higher if you post-dilate it. I don't think that will help.
And part of the reason for the PVL is that intercommissural distance that we were talking about, because we were getting upper end, 30 on the intercommissural, and at the LVOT as well, it was wide in that dimension. So can you guys see can everyone see the hemodynamics?
Yeah.
Yes,
so the LV EDP doesn't looks good to me. You have a nice dicrotic notch. There's not a big upslope in the LV pressure. So these hemodynamics reassure me. In this gentleman, I think this result is great. And I wouldn't post-dilate or I wouldn't try other more aggressive maneuvers to reduce that leak. And I feel comfortable calling it mild based on this and the LV gram and the echo.
And Sushil, I think we agree. Unfortunately, we are out of time. I want to thank the live operators from Erasmus, as well as Columbia, New York Presbyterian for these excellent cases, as well as thank my global panel, Didier Cheche, Roxana Moran, David Hildrich-Smith, and Lars Sundergaard. We're going to turn it back over to Nicholas to wrap up the day. Thank you.
Thank you. Thanks, everyone.
Thank you.
Thank you.
Well, that was an exciting day of advanced structural heart interventions. I think the 2 sessions went very well. The live cases were super educational. I would like to thank Kendra for chairing the 2nd session. I also would like to thank the expert panelists, David Hildigsmith, DJ Chetche, Lars Sundergaard, Azim Latib. What a fantastic job. Also the folks in Leipzig, they did a super pre-recorded case. I love the discussion. I think this was very educational, very relevant to our practice. With that, we wrap up the first day, but please join us tomorrow. Tomorrow there will be a focus on coronary interventions, CTOs, and calcific disease. Again, we will have some breakout symposia. And then the 3rd day, there is Valentin Fuster and more discussions among this great faculty. I'd like to thank the team today for all the great work, and I'll see you tomorrow. Goodbye. Have a good evening.